Okay, Carla?
All right. Hi, everyone, and thank you for watching our group's video debate. My name is Amanda Thompson, and I am from Ruskin, Florida, and I will be the introducer for our group as a whole this evening. Our group will be conducting an informal debate conversing the pros and cons about restraints and seclusion being ethical for people with autism and other developmental disabilities. Seclusion and restraint refer to safety procedures in which a student is isolated from others, which is seclusion, or physically held, which is restraint, in response to serious problem behavior that places the student or others at risk of injury or harm. On the pro side, Hannah Turney from South Carolina will have the role as the illustrator in stating the introduction. Mackenzie Duncan from Bloomington, Indiana will have the role as the researcher and provide the summary. For the con side, Tyra Washington from Neptune, Jersey will be the illustrator in stating the introduction, and Kristen Lubbers from Iowa will be the researcher and provide the summary. I will then conclude the debate and open us up to questions and answers.
Mackenzie and I will be arguing in support of restraints and seclusion as a form of intervention. Restraints and seclusion are commonly used as a form of emergency interventions related to high rates of severe self-injurious behaviors and aggression towards others under the supervision of a trained professional and with the intention of fading out the intervention. Restraint can be defined as any manual method, physical or mechanical device, material or equipment that immobilizes or reduces the ability of an individual to move his or her body freely. This can also include the use of drugs that are used to restrict an individual's movement or behavior. Seclusion is defined as the involuntary confinement of an individual where they are prohibited from leaving.
As Hannah previously mentioned, restraint and seclusion are used as an emergency intervention built in an individual's plan to help prevent that person from causing serious harm to themselves or others. Restraint and seclusion should be administered under the close supervision of a specialist in tandem only to react to the situation when all other interventions currently do not work. Many have deemed the use of restraint and seclusion as unethical and dangerous to the individual and the staff involved. The general feeling is that it is dehumanizing towards that individual. However, other people have felt that it's sometimes the only option that is left to intervene during extreme behavior episodes in order to prevent self-injurious behaviors as well as injuries to others in the vicinity. Most studies that discuss the continued use of restraint and seclusion note its use as an emergency procedure to prevent any harm, and there are strict guidelines on how it is implemented, such as specific training for staff and mandatory reporting procedures. Restraint and seclusion is not generally considered as the only intervention for severe problematic behaviors, but as a last resort procedure when a behavior episode has come to an extreme or harm may be caused to themselves or to others. As stated in an article by Vollmer in 2011, although many persons with severe behavior problems can be effectively treated without the use of restrictive interventions, restraint may be carefully planned and monitored. Restraint may be necessary on some rare occasions with meticulous clinical oversight and controls. In addition, a carefully planned and monitored use of timeout from reinforcement can be acceptable under restrictive circumstances. Seclusion is sometimes necessary or needed. Most agencies and advocacy groups are pushing for a reduction in the use of this treatment method. However, there are clinical situations for which verbal and behavioral techniques are not effective, and use of seclusion and or restraint becomes necessary to prevent harm to the patient and or its staff. There have been multiple articles and studies that discuss restraint and seclusion as a single treatment and as a part of the treatment package. In a 2012 article by LaBelle, it was stated that adverse effects, injury or death, as risks associated with the use of restraint and seclusion are considered low probability but high consequence events. The probability or likelihood that someone will die from a restraint procedure is low if we consider the number of restraints that are performed in a year. Furthermore, they go on to note that the Individuals with Disabilities Education Act, or IDEA, emphasize the use of positive behavioral interventions and supports to address behavior that improves learning. However, it does not prohibit the use of restraints or other aversive behavioral techniques for children with disabilities. Recommendations in the article by LaBelle propose federal legislation, H.R. 1381, mandates the following rules for seclusion. If it impacts breathing, it is unallowed. It is unallowed unless behavior poses a danger to self or others. It is used only by personnel trained in crisis intervention programming. This process concludes immediately on the cessation of behavior. It should not be written in a plan as an intervention, but as an emergency procedure only. And immediately after restraint, documentation is in place, including the notification of parents. Another study was done by Banda in 2012 that included a 14-year-old boy who was diagnosed with autism. He frequently engaged in self-injury. It was noted that in order to escape these self-injurious behaviors, the boy would engage in self-restraint behaviors, such as wrapping his hands up in blankets, and he seemed to find this soothing, according to the research. In this case, restraint was used on the individual towards himself, and the clinicians were able to take this method and gradually fade it out to decrease those restraint times, as well as instances of self-injury. The conclusions of the study showed the outcome of the gradual fading of self-restraint on the child with ASD had the effect of lowering self-injurious behaviors to be at 0 levels. The faded use of restraints, long-term maintenance of reduced self-injury levels, and higher social validity from adults. The limitations of this particular study was that there was no functional analysis conducted for restraint and non-restraint conditions. On the basis of the data presented in this study, one may conclude that the self-restraint served as a negative reinforcement to help the clients avoid self-injurious behaviors. Also, no component analysis was conducted to determine which procedure was responsible for reducing the self-injurious behavior. A different study was done by Peter Pedersen, and it focused on conducting a functional analysis and functional communication training to reduce problem behavior, and in turn, reduce time and restraint. In this case, the client engaged in problem behaviors and had to be restrained by staff as an emergency procedure in order to prevent injury to himself or others. The study chose to implement an intervention, in this case, FCT, along with the functional analysis, but not altogether get rid of the use of restraint during the process, as it was still in use as an emergency procedure. Pedersen noted that in the BACB ethical guidelines for behavior analysts, there are specified instances in which restraint is acceptable, such as in crisis management for dangerous behavior, when it is included in a comprehensive behavior support plan, and where alternatives to restraint have been attempted. The results of the functional analysis and Pedersen's study showed that the demand condition was at the highest level. The client was receiving negative reinforcement through escape of demands. Teaching of functional communication training to the client reduced problem behaviors to near 0 levels. In continuance of FCT, there was an increase in functional responses and a decrease in restraint times. Time in restraint in baseline conditions was at an average of 145 minutes a week. After intervention, the average was reduced to 52 minutes a week. In follow-up, time in restraint was reduced to a further to 5 minutes a week. The limitations of this particular study show that levels of responding were variable in the baseline phase, which reflected transitory states of severe problem behaviors, and the rate was not quite stable. There was also no formal treatment integrity data collected in the study. Other limitations of the study included not having clear consensus of the staff training, was an additional factor in restraint reduction, and not just FCT. The possibility of measurements reactivity due to sessions being filmed by another person in the room. And even the study stated that they did not directly demonstrate that the time in restraint was reduced by FCT, but time in restraint was continuously measured over several months prior to and directly following the intervention, and that showed a decrease. In an article published in 2011 by Knox, the American Association for Emergency Psychiatry, Project Beta, which stood for Best Practices in Evaluation and Treatment of Aggression, reached a consensus that restraint and seclusion is necessary in certain situations in which verbal and other behavioral techniques are no longer effective, and the use of seclusion and restraint becomes necessary to prevent harm to the patient or staff. The consensus of Project Beta was that when the recommended procedures are followed, The use of restraint and seclusion is considered an emergency intervention and only used after other techniques have failed and the situation may result in harm. It should be used and the least restrictive intervention possible should be considered. Knox suggests other approaches to reduce the need for restraint seclusion should be applied, including changing an organization culture where restraint is viewed as treatment failure, implementing an administrative quality management review process aimed at improving outcomes and managing aggressive behavior, regular staff feedback, early identification and intervention using de-escalation techniques, and the use of protocols or aggressive management algorithms to guide clinical interventions. Now, Hannah is going to show a couple of parts from the research that we've just stated.
The following graph shows the client's self-interest behavior per minute during baseline, intervention, fading of the blanket, and a follow-up phase. During the intervention phase, you can see that the subject received reinforcement on a fixed interval schedule while self-interest behavior was ignored. He was also able to hold a blanket and wore a helmet and gloves during any occurrence of self-interest behavior. After this phase, a phase was completed where the blanket was faded out. During the fade-out procedure, you can see where a fixed interval schedule of 10 seconds was implemented, with self-interest behavior once again being placed on extinction. The blanket was systematically cut down in size throughout this procedure, and after 28 sessions, you can see that the blanket had been completely faded out. The following is the algorithm that is used to determine if restraint and or seclusion should be used. You can see that the answers to the questions will help guide you in determining if all aspects have been effectively considered before the implementation of either restraints or seclusion occur. Questions such as, does verbal de-escalation or medication administration effective? Is the patient a danger to others? Is the patient a danger to themselves if secluded? And will the patient sit in a quiet room that is unlocked? All are questions in the algorithm. Lastly, you can find the Peterson graph where they completed a research study on reducing the amount of time spent in restraints using functional communication training as part of an ongoing treatment. The results of the study suggested that the use of functional assessment and ongoing functional communication training may in fact successfully eliminate and or reduce the use of restraints. In the provided graph, you can see the relationship between the use of functional communication training and the reduction in the rate of problem behavior, along with an increase in the rate of functional responses. During my time working in a clinical setting, I worked with a client that was over 5 feet tall and weighing over 150 pounds. This client would engage in self-interest behavior in the form of headbanging against hard surfaces, such as concrete floors and walls, while also engaging in aggression towards those around him in the form of lunging their body towards staff members, biting others, leaving open lesions, and bruising, and grabbing staff members by their clothing, arms, legs, or any other item that they are able to grab. The staff member would be pulled in to make physical contact with the client so that the client could then make contact by biting. These behaviors would be exhibited on average of 1 to 2 times per hour and lasting anywhere between 5 to 30 minutes in length each. The client was hospitalized during this time due to severe self-injurious behaviors and discharged after a medication change that did not decrease his SIB behaviors to a safe level. In the home setting, the guardians would administer medication provided by the doctors and utilize seclusion and restraint to keep the individual and those around them safe. The individual had a helmet available but would not keep it on throughout the SIB behaviors, even after ongoing desensitization procedures and reinforcement during times of wearing the helmet outside of SIB behaviors. Oftentimes, the staff members wouldn't be able to physically or vocally prompt the individual to put on the helmet without being harmed or increasing the SIB. A behavior plan was created to reduce the SIB and aggression towards others, including functional communication training and a high rate of reinforcement that also included ongoing parent training and support to ensure consistency across instructors and settings. The behavior plan also included an emergency protocol for 2-person holds as a least restrictive intervention during times that it was deemed that other interventions were not effective in decreasing the SIB and keeping the client safe. with an ongoing functional communication training, reinforcement of appropriate communication, and compliance with demands and ongoing parent support and training, the use of restraint was decreased to 1 to 2 times per month, and SIB and aggression towards others was reduced to 1 incident every 4 to 6 hours.
As a special education teacher, I work with a variety of students. In recent years, I've had a handful of students that have shown moderate to severe aggressive behaviors, which were not only disrupting to the general education setting, but also pretty dangerous. In one such case, we had a boy of about 10 years of age, and he regularly engaged in hitting, kicking, scratching, spitting at other students and teachers. He would also flip over tables and chairs, throw objects such as sharp pencils, books, scissors, staplers, anything that really could get near him. Naturally, the teacher would have to clear the classroom. At that point, I would go in, I'd follow the steps of the behavior plan, and then the student had in place. The behavior became so frequent, though, that not only was the student receiving all the attention he wanted for that dangerous behavior from us, but other students were not able to learn due to constant disruptions and being removed from the room. And they were also all afraid of this child, in which caused that child more isolation. We knew that we needed to find an alternative. While working with a teacher on those positive interactions and interventions we could use with students to promote those in-class behaviors we wanted, we also needed to have a crisis plan for those outbursts. We implemented a cover removal system for the absolute necessity that he was becoming a danger to himself or others. In this plan, he was moved to an empty room where I followed him into that room. I watched him and logged data and did not interact with him once he was in that room. In these cases, seclusion was necessary for the student to calm down, but also to be away from the other students that they were safe as well. Restraint became necessary in the circumstances when the student would also begin to attack the staff members, or he began to slam his head into the walls, which is something he also frequently engaged in. Unfortunately, the student's family moved from our corporation, so I'm unaware of his progress at this time. When we thought about his plan, though, no one's first reaction was to seclude or restrain this child. We wanted to support him in other ways that he needed help in and promote those positive behaviors. However, seclusion and restraint became necessary in those certain circumstances where the child was a danger to other students, to us, or to himself. As a school, we had a responsibility to keep the students in a safe environment where they could learn, including this child. Even though that learning environment was the best for him, sometimes he had to be removed and secluded. In some individuals, these practices may continue to be necessary for emergencies for everyone's safety involved.
It is our ethical duty as individuals that serve such a vulnerable population to provide the most effective and least restrictive treatment possible. As stated by the BACB Compliance Code in Code 403, programs should be tailored to the individual's unique behaviors, environmental variables, assessments, results, and goals. Sometimes this means that the use of restraints or seclusion as a single aspect of a treatment plan is necessary. However, it should only be used if it is determined to be the least restrictive intervention as stated in Code 4.09.
Kristen and I will be arguing against the use of seclusion and restraints. Seclusion and restraints can be both physically and psychologically damaging to the adult who's performing the task and also to the client or individual who is being restrained or secluded. And due to the physical and psychological damages that seclusion and restraints cause, research demonstrates that this technique for managing difficult behaviors is unethical and that it should also be eliminated.
Overall, our con-side discussion will be about why we believe seclusion and restraints is unethical. Seclusion and restraints can cause psychological damage, physical damage, it's very expensive, and it's discriminatory. Students with autism are more likely to be restrained than students without autism. This is already a population that is discriminated against, and we as practitioners can do our best to lessen that discrimination. Aversive interventions still exist despite the strong push for positive behavioral intervention and supports. Others justify the usage of restraint and seclusion with the need for client and staff safety, despite there being little to no evidence that these methods end in successful behavior intervention and change. Restraints are overused when other interventions could be effective if completed before resorting to restraints. Many practitioners jump immediately to a restraint before considering or utilizing a less restrictive route. Next, I'll be discussing some of the research that focuses on how autism is at a higher risk for restraint and seclusion. An article from Weber in 2014 stated that there was evidence to support that individuals with autism spectrum disorder are at risk for seclusion. In a self-report questionnaire that was done, people reported that a high percentage of the individuals they knew that had been secluded had a diagnosis of ASD. So most of the people that they knew that had been restrained or secluded were diagnosed with autism. Individuals with ASD are more likely to show challenging, aggressive, and destructive behaviors, which are risk factors for seclusion use. In an article by Kathy Yannis, the Office for Civil Rights in 2012 reported that of the 12% of students sampled who had a disability, approximately 70% were subjected to physical restraints. Students who have disabilities are 50% more likely to experience corporal punishment in schools than their peers. Next, I will be discussing a few graphs about how autism is being discriminated against for restraint and seclusion.
So the first bar graph you see is from Weber 2014. And the following graph shows that individuals with autism are more likely to be subjected to seclusion and restraint, which is discrimination. Approximately 55% of individuals with ASD are secluded, and about 35% are restrained. This is in comparison to 35% of individuals with a psychiatric disorder being secluded and about 15% being restrained. Now, as we move on to the next graph, this graph shows students that are subjected to physical restraint. Students with disabilities served by the IDEA represent 12% of students enrolled in public schools, but 75% of the students who are subjected to physical restraint during school. Clearly, restraint is not the norm for students without disabilities. If other methods can be used for those children, why not with children that are autistic? The next graph focuses on students who are subjected to seclusion. Students with disabilities served by the IDEA represent 12% of all students and 58% of students subjected to seclusion in school. Again, seclusion is used more with students with disabilities than with students without disabilities. The minority group is clearly being discriminated against.
Some limitations of those studies, a limitation of the Weber 2014 study is that a majority of the research done on seclusion has been done in mental health facilities with patients suffering from mental health issues. Because of this, there is limited research on the effects of seclusion with disability services. Next, we'll be discussing why restraint and seclusion can be dangerous. From StopHurtingKids.com, the restraint and seclusion violates the No Child Left Behind Act and the IDEA. Seclusion and restraint are not evidence-based practices. Individual liberty is protected under the least restrictive alternative. The least restrictive alternative for each child must consider the child's individual interests, purpose of treatment, and the interventions and environments chosen. Interventions must be demonstrated as effective for the purpose for which they are used and must have proof of therapeutic value. More than 2 decades of peer-reviewed studies have provided strong evidence of positive alternatives for addressing even the most serious behavior challenges such as self-injury, aggression, and property damage. The goal of positive behavior supports is not merely to suppress or eliminate unwanted responses, but to understand and respond thoughtfully to their cause and their purpose. It is better to substitute more appropriate and effective behaviors and make the child's needs known. Here are some reasons to avoid aversive techniques. Children generalize what they learn. If a child experiences fear during restraint in the classroom, they will begin to fear and avoid the classroom in general. Children learn from adults. If an adult gets physical to problem solve, the child will also think it's okay for them to get physical to problem solve on the playground with other kids or possibly adults. It is more helpful to seek the underlying cause of the behavior. Trusting a teacher and feeling safe at school are vital for a child's healthy development. All children should enjoy equal protection from danger and risk, despite having a disability. Children with disabilities should be taught positive strategies, which is the norm for neurotypical children. In Health and Beauty Close-Up from 2011, between 2006 and 2011, approximately more than 200 students, including those with disabilities, have died due to seclusion and restraints being used in schools. A 2009 Government Accountability Office investigation reported that thousands of students have been physically injured and emotionally traumatized as a result of restraint and seclusion in public schools. Next, I'll discuss a few specific cases. Students have been reported to have died from mechanical compression to the chest or smothering. A school child died from hanging himself in a seclusion room. A 4-year-old girl was tied to a chair as a form of restraint and abuse. 5 children were duct taped to their desks as a form of restraint. And a 10-year-old boy who was put in a seclusion room 75 times over a 6-month period for hours at a time for offenses such as whistling, slouching, and hand waving. These cases may seem extreme, but over time, all restrained seclusion can turn into extreme circumstances. In an article from Weber in 2011, behaviors perceived as harmful, destructive, or disruptive are likely to result in a restrictive intervention that can impact the liberty of the disabled person. Skill development and environmental enhancements are preferred and evidence-based. Restraint and seclusion is debated over the clinical merits as well as the human rights issue. Besides physical restraint, chemical restraint is the most commonly used. Mostly psychotropic meds are used. It's also used as a routine, not as an emergency or as needed. An Australian study reported that 5% of the people receiving an intellectual disability service were reported to receiving chemical restraint on a regular basis. The majority of these were prescribed antipsychotic medication for routine use. The classification of a medication as either a restrictive practice in relation to behavior or as a treatment in relation to a mental health problem remains controversial. Problem behavior, when it is viewed as a mental health condition, legitimizes the use of medications as treatment. Some limitations of the study of the Weber 2011 study is that there's a low number of cases of restrictive interventions. The prevalence rates of restrictive interventions are difficult to determine, and restricted interventions are defined differently across jurisdictions, and data is collected differently. Next, I'll discuss the cost-effective research of eliminating restraint and seclusion. From StopHurtingKids.com, they talk about the Grafton School Incorporated, which is a nonprofit in Virginia serving children and adults with autism and other diagnoses. They have a long history of using restraints, and they issued a restraint reduction effort. The CEO said he wanted to eliminate restraints without compromising employee and client safety. They use key reduction strategies to do this, such as leadership oversight and review of every event, supporting clients in crisis, providing staff with training, tools, and management support. So since 2004, they had reduced restraint by 99.8%. Some of the benefits of this were reduced client-related staff injuries, reduced staff turnover, which saved the company over $500,000, reduced employee lost time and lost time expenses, reduced number of workers' comp claims and the cost of those claims, reduced liability premiums, and increased staff satisfaction and staff perception of greater safety on the job. Next, Tyrell will discuss a graph from the Grafton case.
So if you look at this line graph, it shows the reduced amount of workers' comp in relation to time spent eliminating restraints. So as you can see, as more restraints were phased out, money was being saved due to less workers' comp filing. And besides being safer, more ethical, and more inclusive, reducing the usage of restraints can save a company money. Now I'll give you a personal example. I currently work for a company that provides in-home ABA therapy services to children with autism. And from the beginning, I was told that our company had a no restraint and seclusion policy. And in my experience so far at work with challenging and aggressive behaviors, I have never needed to restrain or seclude a client. I have been very successful at determining the function of behaviors and being able to ease the situation and calm the client. So this proves that it can be possible to have a great and safe work environment without restraint and seclusion. Now, Kristen will give an example.
The first company I worked at provided restraint training. While we were trained on how to properly do restraints, I never had to resort to using one. Our first line of defense was always de-escalating and trying to find the cause of the challenging behavior. I never felt unsafe where I worked, and not every employee was restraint trained, but there was never an occasion where an untrained employee needed to restrain and wasn't able to. It is possible to work in an environment with individuals with autism and challenging behaviors without performing restraints. Next, Amanda will share her experience.
While working at a school that used physical restraints and seclusion, I observed that it seemed to have caused adverse physical and psychological effects on both staff and patients. There were many times where I've seen individuals fight and tense up during a restraint and yell in pain because they are fighting it, and it starts to really hurt. I have seen staff get hurt numerous times while the child was put in seclusion rooms because the staff would have to block the door so the child would not escape. And a lot of times their aggression, they would try and take it out on the staff in those rooms. It appeared that the seclusion rooms were a lot of times an escape for most of the children, and it seemed to encourage their behavior because they got out of what they were doing. When children were being physically held down to where they cannot move freely, it seemed to be very scary and traumatic for some of them. And a lot of times they would just start screaming the whole entire time.
It is our duty in the field of ABA to provide considerations regarding punishment procedures. Part A of Compliance Code 4.08 recommends that behavior analysts use reinforcement rather than punishment. Seclusion and restraint are not reinforcers. That will conclude the con side.
Now we will do questions and answers. So the first question is, a lack of training may be a potential issue for those who perform restraints. Are there any strategies or methods that can help improve training for administering restraints and or decrease the need for restraints? Hannah's going to answer this part first.
A lack of training is a valid concern and ongoing issue in relation to restraints. To combat this concern, the ABA company I provide services through has mandatory training for holds and self-defense. This training consists of an online video presentation portion with questions, in-person training where role play is completed, and mastery must be demonstrated in a written test. Each staff member must be trained by a certified trainer and signed off as mastering the holds and self-defense methods before being able to assist with a restraint or call for restraint to occur. Each staff member is provided with ongoing feedback and training throughout the year, along with being recertified periodically. When restraint is used, extensive documentation is completed by all staff members, and an in-person review is completed with all staff members involved in the restraint. During the meeting, staff members discuss the restraint that was used, the circumstances surrounding the use of the restraint, what could have been done differently, and how the restraint could have been avoided in the future.
Strategies to reduce the use of restraints is to use them only as a last resort after attempting or exploring alternatives. Alternatives include having staff or a family member sit with the client, using distraction or de-escalation strategies, offering reassurance, using a bed or a chair, alarms, and administering certain medications. If appropriate, alternatives have been attempted or considered but have proven insufficient or ineffective or are deemed potentially unsuccessful, restraint may be appropriate. A provider order must be obtained for client restraint. Be sure to update and revise the care plan for a restrained client to help find ways to reduce the restraint period and prevent further restraint episodes. To help reduce these risks, make sure a physical restraint is applied safely and appropriately. With all types of restraints, monitor and assess the client frequently. To relieve the patient's fear of the restraint, provide gentle reassurance, support, and frequent contact. You need to monitor vital signs if possible, like their respiration and pulse, to make sure that they're still breathing and everything, to help determine how the patient is responding to the restraint.
Question number 2 is the use of restraints in seclusion vary from setting to setting. For example, in Indiana, mechanical restraints are not recommended to be used for people in adult services. Is it ethical to use this as a way to address behavior if it is not something that can be used across various settings? What happens if a child has a mechanical restraint in one setting, but then moves to a new setting where that type of restraint is not allowed?
It is important to know each state and company policy regarding restraints and seclusion before either providing services and/or seeking services for an individual. If it is determined that restraints and seclusion is the least restrictive and effective treatment plan for an individual, it would be important and one ethical obligation to seek a state facility that is able to effectively provide the least restrictive and most effective treatment for that individual. Each state lists their policies on restraint and seclusion, and you can go to www.ed.gov/their policy on seclusion, and it'll give you a summary by state, letting you know what their policy is on restraint and seclusion. And the third question is, do you have any personal experiences related to this topic that you would like to share? And Mackenzie is going to answer this one.
Yeah, so working in the public school system, in recent years, we've had more seclusion restraints than before. It's not for the lack of trying positive methods. We do employ positive behavior intervention support through the building. We do smaller tier supports for smaller populations of kids and behavior plans for those kids who need that really big individual supports. What is the issue as we face most often is that if a child just becomes out of control, danger, which means they could hurt themselves, hurt a classmate in their room, we can no longer keep them in the room, even if that's the best place for them. In a room with 19 to 22 other students and adults, we have to think of all the other kids first and foremost. We have to think of the whole more than the individual in that second. We have to think of this is where seclusion comes into play. We use the seclusion with ourselves in the room, monitoring but not engaging, to let the student calm down and to monitor them for self-injury behaviors if they do appear. On one occasion where the child begins harmful behaviors, we have to restrain them. And this is done only by people who are on a specific CPI team, and we have specific procedures in place for when this does occur, including monitoring of the student by multiple adults and data collection and notification of parents. Our ideal is for these students to follow the behavior plan, which includes positive and proactive strategies to address the behaviors. We use seclusion restraint as that last resort in most of these cases. We are limited, though, as a school, in how long we can keep the aggressive behaviors in a room with the other kids until it becomes upsetting and traumatizing to those students as well. We try to work with these methods in as a crisis plan. It's not something that we really enjoy doing, but when we have a very big room full of people, lots of objects in the room, sometimes seclusion might be the safest thing to be done for the majority at that time.
All right, and that concludes our debate.